On the Scale podcast. I'm your host, Dr. Spencer Nadolsky. With me today, we have one of the people I respect probably more than anybody on the planet, Dr. Bob Kushner. Are you gonna start blushing now? That's all right.
That was very kind and
Very
unneeded, but
kind.
I appreciate it.
No, it's true. Um, Dr. Kushner is a professor at Northwestern University, their medical school, and also leads their lifestyle medicine clinic, and also one of the founders of the American Board of Obesity Medicine, of which is where everybody knows of obesity as a specialty now. And I got certified, I think, in 2014, almost like right when it started, a year or two after it started. So today, we're going to be talking about the history of anti-obesity drugs, because I think it's really important for people to understand the history, because where we are now, it's all the buzz, but this concept has been out for quite a while. So thanks for joining.
It's a pleasure, Spencer. Thanks for having me.
Okay, so let's kind of get into this history of anti-obesity, or people call them weight loss drugs in the past, and we're trying to get away from that term. And maybe you can just explain why we're getting away from that term weight loss as opposed to uh, anti-obesity medicine. It's kind of an interesting change in how we.
I think that's a good point you make up. People often think of and they come in and go, "I want to lose weight. I want medications." But as the whole field of obesity has evolved, it's very clear now that weight is a metric of health. When in my own program at Northwestern, the number is not 1-800 thin. That's not what I'm trying to help people achieve. I'm trying to help them get healthier. And that involves diet, physical activity, sleep, hygiene, reducing stress, dealing with all the chronic diseases and getting their weight under better control. So I agree with you. A much better term is long-term weight management or medications that help with weight management. I don't actually like the idea of anti-obesity medications. I don't
Yeah.
like anti-anything, right? But I think, Spencer, I think the terminology we're going to end up with when it comes to these medications will vary. I don't think it's
Yeah.
going to be anti-obesity medications. It gives the
That's a great. I'd love to discuss. I don't have a. I don't really care, honestly. I just want to help, like you said, people get healthier. Whatever, change the stigma around these medicines. Change it from vanity weight loss and that type of thing for whatever that new term will be. I like that. So, what what were the like original medicines that were used for weight loss or obesity management in the past, like the 1900s, early mid 1900s?
Well, I'm not as much of a historian as I think you make me out to be, but my understanding, where the story begins, at least with my own knowledge, is amphetamines.
Yeah,
Although it may have begun earlier with thyroid stimulating hormones or
yeah.
things that produce heat. But where the story begins with me is the use of amphetamines, probably in the early 1900s.
Mm-hmm.
And it was observed that as one took amphetamines, they reduced their intake and often lose weight as a kind of a side effect of the stimulant properties. So that I think some pharmaceutical companies got intrigued and tried from a pharmacologic point of view, how can we reduce the addictive potential of amphetamines and highlight the weight reduction or appetite suppressing effect of amphetamines. And that's where these amphetamine derivatives came from. So if you just take a structure of amphetamine, you can change the side chain, aliphatic side chain, and you develop derivatives like phentermine or
Mm-hmm.
diethylpropion. They're under the amphetamine family, but they've changed enough that you don't get the addiction potential. And Spencer, as well as all of us in the obesity field, you can't get a lot of money for phentermine on the street. You don't get that high
Mm-mm.
with
Yeah.
phentermine. It is not addicting from all of us who have used it, but yet it harnesses the appetite suppressing effect. So that's, I think, where the story began. And to my understanding, that is the first drug approved by the FDA, I believe in 1959,
Mm-hmm.
were these amphetamine derivatives.
And so the thing is, though, it was approved for only 12 weeks at a time. So this kind of gets into the whole chronic management of weight or obesity or whatever. I don't know the specifics of why it was only approved for 12 weeks of a time, but I have a feeling it was because they didn't view obesity as a chronic disease back then. I mean, I don't know.
Yeah.
You might know better.
Yeah, no, I think you're right. I think two things come to mind to me. One is that at that time, the whole idea of randomized controlled trials that are blinded, that are long enough in duration, and this whole idea of how we view safety, efficacy, and tolerability was different in the 1940s and 1950s. That's one thing. So short-term trials, I think, were probably part of the regulation at that time. So it was never studied beyond 12 weeks. But also importantly, and you bring this up, Spencer, is if you look at the indication for phentermine, it's approved for exogenous obesity, right, for short-term use. Clearly obesity was not thought of as a long-term chronic relapsing disease like it is now. And they really thought of it as this idea, I believe, as the self-will. If we could just improve appetite, the behaviors kick in and people could become self-reliant on their own behaviors and their own determination. So the whole concept of obesity was very different. And the whole idea of safety and efficacy of randomized controlled blinded trials really were not really created at that time.
Yeah, and you're a trialist. Why couldn't they go back and change it? It would require a large study. Does that sound right? And somebody would have to pay for it and manufacturers. It's generic now. I don't know if that has to do with it.
Well, two things. One is you're right. Who's going to take a generic drug and put the money involved in a randomized controlled trial? Well, I'll tell you who. It's named Jamie Ard,
Yeah,
who's
no,
one
I
of our
know.
colleagues. So
Yeah.
Jamie Ard is currently conducting an NIH study at about, I think, 5 medical centers, I believe, doing the very first long-term randomized study of phentermine versus a placebo among individuals living with obesity, and really understand in a scientific method its effectiveness, its tolerability, its side effects, risks, and so forth. And that study's not going to be done for several years. But if you have him on your podcast 4 years from now, Spencer,
Yeah.
I think you're going to have the answer for
We're
phentermine.
we're gonna mark it down. Yeah. So for anybody listening, we did this scientific advisory board meeting, and we are going over it. It sounds really interesting. The other component about phentermine is that because it's amphetamine-like, despite it not being addictive, they have it in a scheduled drug, which gives us a lot of limitations. We can't do it. We can't prescribe it online. That might change but right now you have to see somebody in person, and then you're supposed to see them at least like once a month. I think that's reasonable, but and checking in, but you can't do it online. I mean, with COVID, there were some regulations that changed, but temporarily. But hopefully, that's something that somebody can look into too. So, do you use phentermine a lot?
Well, I think it's worth noting that phentermine is the most common medication prescribed in the United States for the treatment of obesity. It really, it just surpasses all the other branded medications. I think the reason is one, it's cheap,
Mm-hmm.
and as I do, the access and affordability is a huge problem regarding this whole family of medications. So phentermine cuts through that, and because it's generic and cheap, it is the most commonly prescribed medication. And I think among prescribers, I think they have the greatest familiarity with it. I also prescribe it, particularly when one does not have health coverage for the other branded medications, which are arguably more effective and approved for long-term use. But we're in the business of helping people, so if that's what's available, that's what we're going to use, and we monitor them closely, of course.
Okay, so thinking about these newer drugs that we have, and thinking about phentermine, what's the total, like relative total amount of body weight loss on average, percentage wise, that you could get from phentermine monotherapy, meaning by itself? Like if somebody can't afford these GLP-1 medicines, they don't respond to, let's say, Contrave or bupropion naltrexone or something like that, or maybe they can't even afford that, whatever, and they can get phentermine from their local doctor. What's the average around there based on the studies? Is it uh, 5 to 10%? That type of thing.
Well, I think that is about right. I think it is probably 5 to 10% weight loss. As we just said, there are no randomized long-term trials. You're talking about individual reports, anecdotal reports from single center trials or observations. but I think that's about right at probably 5 to 10%. You also know that there is a heterogeneity of response. Some people do very well on phentermine. Some people do not as well. The other thing, Spencer, I think we want to highlight when it comes to phentermine is a unique aspect of these kinds of medications, and that's called, medical term is tachyphylaxis, which is you develop a tolerance. And I think anyone who is abusing medications, let's say amphetamines or others, know you have to take higher and higher doses to get the same effect. Now, that relates mostly to getting the high that you get from a stimulant. With weight management, patients will often tell you that I just don't feel the same appetite suppressing effect with this drug. Now, part of it may be the body's regulation, because even on these branded, more effective medications, patients will tell you as time goes on, I'm starting to feel hungry again, and so on. But we think that's more a kind of a regulation of appetite within that individual and the drug. Phentermine is probably the same thing, but it's voiced all the time. And I'm sure you may have
Yeah.
seen your own private practice. They say, can't we go up on the dose? I don't feel the same type of impact.
Yeah, it will be interesting if they can get a longer term, if Jamie can do this trial, because that's what everybody says, the tachyphylaxis with phentermine specifically. I do see it with the new GLP-1s, but their weight is staying low. I'm just like, well, just eat more then. Let's see what happens. But with phentermine, if we can see the trial, it would be interesting to see, do they maintain, is it durable? Do they keep that nadir of their weight loss? Or does it just start going back up?
Yeah, that is. I'm looking, and Jamie Forrest, by the way, is at Wake Forest Medical Center, so that's where he's located. And he's doing this study with multiple centers. I commend him for doing it because
Yeah,
it has not
very
been
cool.
done until now. So I wish him a lot of success in doing it. It's a long-term study to maintain people on these medications. It is not easy as a trialist, but
Yeah.
I'm looking forward to him carrying that out successfully.
Okay. Yeah, I'm excited to see what he does. What are the doses that come? So there's 37 milligram, 37.5 milligram. There's a 30 milligram dose. What do you use for phentermine with patients?
The other dose is 8 milligrams. The
Yeah.
trade name is Lomera. I will often use a 15 milligram dose. That's probably the most common one I use in individuals who feel that stimulant effect, which is uncomfortable, insomnia, jitteriness, things you can get from a stimulant. I will use the lower dose, which is 8 milligram, in someone who is elderly, where I'm concerned about their blood pressure or cardiovascular effects. I will also use an 8 milligram dose. The other thing about the 8 milligram dose is that it is FDA approved for multiple dosing throughout the day. So unlike the 15 or 30 or 37.5 milligram capsules or tablets, the 8 milligram tablet is approved for a TID, or 3 times a day dosing.
Yeah.
Having said that, I'll often use this 1 or 2 times a day, and patients do fine.
Yeah, I see that too. All right, we're going to switch into then, let's kind of get into that fen era of the 90s. Can you explain what fen is?
So fen was used in the early 90s, 92, 93, 94, and it was dubbed fen. And what it actually was a combination of two medications, phentermine, which we thoroughly discussed right now, combined with another drug called fenfluramine, which was called Redux back then, or Pondamin, that was the other name for it, which was a serotonergic agent. So, on paper, and Michael Weintraub is the investigator who actually did these trials and published quite extensively on them. Theoretically, it made sense. You have a norepinephrine agonist and a serotonergic agent. So you have this phentermine and serotonergic agent working together as a combination drug on appetite suppression, and it was very, very effective. I was practicing back at that time, and just like now with the GLP-1s, receptor agonist, Spencer, everyone was calling in at that time.
Oh man.
Can I get fen? Because it was quite effective. Rather than 5 to 10% weight loss, which is what we were just talking about, they're going up 15% weight loss, 10
Wow.
or 15% weight loss. Very, very effective. Unfortunately, it wasn't subjected to randomized long-term controlled trials like we would today. And shortly after this widespread use of phentermine and fenfluramine together, called fen, A very interesting observation was seen first at Mayo Clinic, and that's who brought it to New England Journal of Medicine publication. And that was left-sided valvulopathy. It was atrial valve and mitral valve insufficiency.
Hmm.
And some of them needing heart a valve transplant and getting quite sick. When they actually looked at the valve, when they took it out, replaced it, and so on, it had a carcinoid-looking appearance, like carcinoid syndrome, but that always occurred on the right side of the valves when you have carcinoid syndrome, which is a serotonin throughout the body. And it turned out, with enough investigation, is that there are actually serotonin receptors on these valves. And the drug activated these serotonin receptors, which causes thickening in the poor function of the valves. And you ended up with cardiac insufficiency or valvular insufficiency. Well, that brought a rapid end to fenfluramine being on the market. Redox was the name of it, taken off the market, I believe in 1996, if I'm not mistaken. And phentermine got a black box warning saying maybe associated with valvular insufficiency, but it was really the company it kept. It was the combination of the serotonergic drug that did that. And to my knowledge, phentermine has not caused valvular dysfunction since that time.
Yeah, okay. That's really scary. You're trying to help people improve their health, as you mentioned at the beginning of the podcast, and then all of a sudden we're worsening their health despite losing weight. It's something that we don't want to do. People want to lose weight for vanity purposes, but as physicians, we want to do no harm. So for anybody listening, that's why we're like, we don't just hand these drugs out for vanity weight loss. We want to make sure we're having improvement in somebody's life in terms of health, quality of life, all these different things. Okay, so what about then sibutramine? Because that's the next one that was kind of around and then got taken off.
Yeah, so sibutramine also was approved in the late 1990s, and we are still within the generation of, like, let's say, first generation medications, where it was a tough nut to crack. How do we actually help people manage their appetite or address obesity? And all the thinking was these neurotransmitters, dopamine, norepinephrine, serotonin. That was the target right in the brain. So sibutramine was an SNRI, serotonin norepinephrine reuptake inhibitor, SNRIs. And many listeners know those as antidepressants. They're SNRIs. So this one was an SNRI, but unique to focus on the particular receptors they had to do with appetite regulation. That's what sibutramine is. It was effective, that 5 to 10% weight loss, like we were just talking about, a once a day administration. However, had the side effects of these other stimulants, like increased blood pressure, increased heart rate, and that was a downfall. That was a concern with these medications. Because of the concern of a cardiac risk, the European agency went ahead and did a randomized controlled trial of sibutramine, wait for it, in patients at risk of cardiovascular disease. Now, interestingly, Spencer, you and I and others would not often be cautious giving sibutramine in individuals at high risk of cardiovascular disease. But the European group said, let's really test this in people who can be harmed.
Yeah.
So they did the trial with serotonin, and sure enough, they had increased cardiovascular events taken off the market because of that, and we no longer have Meridia. That was the trade name. In retrospect, it was actually a pretty good drug, and they tested in a group we would never use it in. I still quite can't get my head around that, but that was the death nail for sibutramine.
They really wanted to stress test that one. I mean, I guess the thing is, like, that and fen really put I would say, a black eye on obesity medicine as a career and as obesity as a disease and all these pharmacotherapies.
Yeah, it's the legacy of these types of medications in the graveyard that I think have dissuaded many prescribers and discouraged them out of, I think, fear. And some of it, safety, of course, we're always thinking about safety, but in my own colleagues, even at my own institution, who may still not use medications for weight management, still conjure up, but are they safe? Aren't a lot of medications we use unsafe? And they have this legacy of fen, as you're saying, and sibutramine, Belvikin is another one, which is a serotonergic agent that was taken off the market for concern for potential cancer risk. That's where their mind goes right away. And as you know, we're in a whole new generation of medications now that have a long term use for diabetes. Hundreds of thousands, if not millions, of individuals across the globe have used these medications. But you're absolutely right. It's been a hard road identifying medications that are tolerable and safe and effective for the treatment of obesity.
Yeah. So then there's fen-phen, sibutramine. The next one that I remember, it was late 2000s, early 2010s, was Qsymia, which is a combination of phentermine and topiramate, which is still on the market at least. It hasn't shown, we haven't taken that one off. So could you explain that one?
Yeah, you're right. So Qsymia is still on the market. Qsymia is a combination medication. So now we're entering into a whole arena of combination medications, which again makes sense because if you treat diabetes, hypertension, asthma, right? We always use even cancer. We use combination approaches. So it makes perfectly good sense. So Qsymia is a trade name for a combination of phentermine, which we thoroughly discussed, but at a low dose, combined with another medication called topiramate. Now, topiramate is approved by itself under trade name Topamax for the treatment of migraine prophylaxis and seizure disorder. So the history of topiramate is interesting. When they did the epilepsy trials with topiramate, a side effect that was noted in the subject logs was weight loss. So it turned out that topiramate had unexpected weight loss in the trials for epilepsy.
Wow.
So that then began trials by itself as a single-alone agent for obesity. And it turned out it was fairly effective if you give topiramate by itself. Unfortunately, the higher the dose you get, the more cognitive dysfunction you get. So word finding problems, confusion, not thinking clearly. So that was dropped as a potential weight management drug. However, when used in lower doses and in combination with phentermine at a lower dose, it turned out to be a pretty effective drug. In fact, it is, by randomized controlled trials, the most effective oral medication we have on the market right now. And it's available in 4 different doses that we can use as clinicians.
Yeah. It's the best non-GLP-1 weight management drug we have. That's why it's really too bad phentermine's controlled, because I really would love to use it in our telemedicine platform because it is so effective, but because of how it's scheduled, we can't. So I love that they lowered the doses. In fact, with the phentermine in it, at high doses of phentermine, you get anxiety, increases heart rates, people like can't sleep. With the lower doses, with that and the topiramate, you don't get the I mean, you do still see side effects once in a while, but you don't get them nearly as much as if you use those monotherapy, just one of them, and cranked up the dose. So I really like that drug.
Yeah, I do want to make one more thing on Qsymia before you go on, though, and that is none of the drugs we use for weight management are approved during pregnancy.
Yes.
And if you intend to get pregnant, stop medication 2 months before. If you find out you're pregnant, stop, and so forth, because it has been tested. However, with Qsymia, there's an absolute red line contraindication to use of pregnancy. In fact, there's a REMS, which is a mitigation strategy that people take. It's a course in order to how do you counsel individuals on Qsymia and make sure you're always asking for and testing for pregnancy. The reason is that topiramate and other drugs, anticonvulsants like that, it's an anticonvulsant as well, as I said, for seizures, causes birth defects, particularly cleft lip and cleft palate.
Mm-hmm.
So you never want to get pregnant on the drug. So when I use it, we are always ensuring the women of childbearing age are using birth control, either IUD or double barrier method, and always asking them, are you, that you cannot get pregnant on this drug.
So the funny thing, so this came out when I was in residency in 2012, and I had a patient in residency who I still see now. And the joke was, every time, because that was ingrained in my head, every time she would come in, I would ask her, and she'd always be like, I had a tubal ligation. And every time I'd ask her, she's like, I had a tubal. I'm like, you know what? I'm going to remember this and make a joke about it when you come in, because even after having, I was just so like, that was my habit. Always like, hey, are you on birth control? That type of thing. So yeah, it's good to note that. So anybody listening, it's these new GLP-1s. We're worried about things. We don't know of any teratogenic effects, but with topiramate, we know for sure that it could cause cleft palates and that type of thing. So it's a little bit more important. What about Belvique though? That came around the same time as Qsymia, and you mentioned it earlier. What happened there?
So that drug, if we go back to the story about those left-sided valvular heart disease, or carcinoid type valves, and we found out that they were serotonin receptors, it turned out specifically they were 5-HT2B B receptors, B for bad. That's how I always
That's
remember
the only
that.
way I remember.
Yeah. So when Belvique came around, they developed a drug that was a serotonin receptor agonist, but it was a 5-HT2C. So it's a different serotonin receptor. And they did randomized controlled trials. The drug actually was effective, although it's really in that 5 to 10% weight
Mhm.
loss. It wasn't a blockbuster, but it was helpful. And the drug was called lorcaserin. That was the trade name. Belvique was Belvique. Excuse me. Lorcaserin is a generic term. Belvique is a trade name. And the drug was actually very helpful because it had no cardiac stimulant effects. I found it very helpful for individuals who could not take a stimulant drug like phentermine or the Qsymia. But when they did their cardiovascular outcome trial, which never got fully completed, but the interim analysis of the cardiovascular outcome trial showed that there was a statistically or nearing a statistical increase in development of some cancers. And it wasn't powered for that, but that's what it showed. And at that point, the manufacturer pulled the drug from the market, and that was the end of lorcaserin.
They never. I always wanted to know what cancers. Is it just all cancers, or do they? I never got. I don't know. Maybe it's closed data that we'll never know. Maybe you know because you're a trialist. You're in the know. But I never heard about which specific cancers, because I did use the drug with some patients. So it's kind of interesting.
Yeah, I don't recall if that is available, Spencer. I don't recall
Yeah.
offhand which cancer in particular, but it was called they call it as an imbalance. That's kind of was
Hmm.
an imbalance in a number of cancers in this randomized controlled cardiovascular outcome trial, but enough so that it spooked the regulators and the manufacturer, and the drug was taken off the
Yeah.
market.
That's another thing that could scare people, because this has just happened a few years ago when they announced that. The one, interesting thing with that drug, I had patients that said, I don't feel like smoking anymore. I don't know. It's off the market now, so we'll never know there. But patients did tell me they just stopped smoking all of a sudden with that drug, despite not that much weight loss. Kind of interesting. Okay, so then the next one that got approved was Contrave. Um, and maybe you can talk about that.
Yeah, Contrave actually is the last of the first generation drugs because, again, it's focusing in on these neurotransmitters and targets within the brain without paying attention or not really taking aware of the hormonal signals that come from the gut and so forth. So Contrave is a second of a combination medication like the Qsymia story. But the combination drugs here are naltrexone and bupropion. So these are drugs that are familiar to all of your listeners, right? Bupropion is approved as well, Butrine or Zyban, which is for depression or for smoking cessation. Everyone is familiar with bupropion. With naltrexone, that is an opiate blocker. Most people know it as naltrexone. There would be another one. This is a different type. It's an opiate blocker. And it turns out that these drugs in combination cause weight reduction. And the opiate blocker kind of allows the bupropion to be more active regarding appetite suppression. Spencer, bupropion was also looked at as a weight reduction drug by itself because, and again, everyone knows if you that it's weight neutral or causes weight loss in treating someone with depression. That drug was also studied as a weight reduction drug, but as time went on, subjects regained their weight while on the drug. So it never went very far. And when you add the naltrexone, it keeps the bupropion more active. It kind of reduces the downregulation of the drug. action. So it's more effective that way. So I'd say it's modestly effective, the 5 to 10% range. I do use it when patients can be benefited from it. This brings up one other point that's worth mentioning. It's called dual actions, or you would use a drug for more than one reason. And if you have someone, for example, who is trying to stop cigarette smoking or has depression, since bupropion is already in there, you may want to think about going ahead and using that drug. So that's one of the values, I think, of using that kind of a combination drug.
Yeah. Yeah, I kind of same kind of thing, and it also the theory behind it is more in the reward pathway. Uh, Despite, like, I know they talk about the satiety centers with the POMC and the arcuate nucleus, and how the naltrexone downregulates that auto regulation that would make people not lose weight. But the other hypothesis is because Wellbutrin works in, it helps with smoking cessation, and naltrexone can help with alcohol cessation, that maybe some of that helps with that reward pathway signaling. I don't know. And you do a lot of the phenotyping type of stuff, so maybe you've seen that. I do the same thing with this, but it'd be interesting to actually study it more rigorously.
Yeah, I mean, I have to say, using the GLP-1 receptor agonists as well as the GLP-1 GIP
Yeah,
dual agonist now, I find patients also have effects of I don't have cravings, I don't have
yeah,
interests. Foods that used to call me out no longer call me out. I think that the whole idea of the reward systems is also targeted by using these newer drugs as well.
yeah. Well, okay. So we talked about the history. We always talk about the GLP-1s, but I do want to note that you were part of the step one trial, weren't you?
Yes.
Did you run it? Were you the head guy?
I was the officially the corresponding author on the New England Journal. So myself and John Wilding from the UK were the two lead authors on the trial. But as you know, it's a global trial, hundreds, dozens of investigators, hundreds of people working on the trial. But John Wilding and I were both the corresponding authors.
Don't be too bashful here. You can play it up a little bit, but it is important. So just for anybody listening, semaglutide, or high dose semaglutide, Wegovy 2.4 milligrams. Dr. Kushner here was the corresponding lead author of the first STEP trial, which is the study of all these high dose semaglutides in obesity. So do you want to make any comment there? We don't have to get into it because we talk about it all the time in this, but like anything from that trial that you saw that was just like, and you're the one that came up with this is a game changer, isn't that your quote? This is the
Well, I quoted. I don't know if I came up with it, but I
no, but
did use
that's
that
why
quote.
everybody keeps saying it's a game changer. But I think you were quoted in, what was it, the New York Times or something? If it pops up, and in fact, I think we've even used that quote on our website before. But any, anything from being the trialist on that, and some of the lessons learned, anything there.
Yeah, well, just a few comments. I do remember being in the room because I was at the board meeting with Nadolsky, is the manufacturer, where they actually revealed the results. And I really do remember all of us in the room, our mouths are hanging open, really. And that's where that game changer idea comes from. The reason we had our mouths open in awe was, one, the amount of weight loss that was achieved we had not seen before. Average weight
Yeah,
loss of 15 to 17%, depending on
it's
how long
amazing.
you're on the drug. And one third of individuals losing 20% or more of their body weight. We've never seen that before. Second thing we are just in awe is that in most of the drugs you and I just reviewed, weight loss plateaus or stabilizes at about maybe 4 to 6 months, and then you maintain that weight. This was the first drug, in addition to the effectiveness of it, is that weight loss occurred all the way out to 1 year, with 68 weeks, which was the end of the trial. So and lastly, it was a game changer in the sense of a paradigm shift. I mean, all the drugs now that are being studied for obesity are mimics or replicating pancreatic and intestinal hormones that regulate appetite: amylin, glucagon, GIP, GLP-1, and a few others. The other thing I'm going to mention, Spencer, is we also did a step one extension trial, which
Hmm.
also a corresponding author on. And that also is very, very important learning for all of us. And that is, we took a little over 300 of the subjects out of 2000 and watched them, observed them for another year. What happened? No surprise, but it's very important to document it, is when you stop the drug, the weight comes back. In fact, individuals where they lost 15 to 17% of their body weight they regain 2/3 of that weight within 1 year.
Yeah.
So good learning point. You got to stay on this drug because it's a chronic relapsing disease.
Yeah, that is a good lesson. And I know they had the step 4 trial where they randomized them to a placebo halfway through, and those people started regaining their weight as well. The people that were re-randomized to placebo and versus those who stayed on the drug. It is interesting, though, you note that they kept losing weight after even 6 months. It does go this. It's steep at the beginning, but there is a continued slow decline even after that 6 months. And some people are mentioning that the weight will come back, like you said, the tachyphylaxis. But was it the step 5 trial? It's 2 years now. We have 2 years of durable data, and is there? I assume there's going to be more trial data coming out of extending it to 4 years, 5 years. I don't see
Well,
patients regaining their weight on it, but
yeah, well, I think the most exciting trial to look at is called the SELECT trial. And the SELECT trial is the cardiovascular outcome trial using semaglutide 2.4 milligrams in individuals who do not have diabetes. So it is the very first cardiovascular outcome trial that I'm aware of that is testing the question: if individuals at high risk of cardiovascular disease lose weight and keep their weight off, who do not have diabetes, does it reduce cardiovascular events? The only obesity trials that have shown that thus far are bariatric surgical trials.
mm-hmm.
We have not seen that in pharmacology trials. So the SELECT trial will be the first one. Average use is over 3 years, so it'll be a little longer than that step 5 trial you just talked about. And that's going to be read out this summer. So if that's positive, Spencer, you're going to want to talk about that on this podcast.
Yeah. Who's leading that one?
It's well, I'm on the data safety monitoring committee for it, but it's a global trial.
Okay. We may have to get you back on it to talk about the trial.
I'd be happy to.
Very good. Seriously, thanks so much for coming on. Anybody listening to this, if you want someone to, learn about the history of weight management or anti-obesity, whatever we're going to call these medicines in the future, please give this a share. Make sure you give us a nice little review. And remember, Dr. Kushner, he is on the WeightWatchers Scientific Advisory Board, but I consider him with us too. Not that they own us, but thanks so much for coming on, and we're going to have you on again.
It was a pleasure, Spencer. Thank you.